Good evening. This is Dr. Teresa Larson, the host of the My New Normal podcast. Welcome to Season 1, Episode 2. This episode is fairly short. It is an educational episode. And essentially, every other week, we'll have educational episodes that will educate you on either the upcoming guests or the series of guests that are coming up. So in this educational episode, we're calling this the wheeled life. So those that are in wheelchairs and what puts them there. And this educational episode isn't to tell their story necessarily, but to give you a background on their condition. And it'll help set the stage for understanding kind of what's next if you're someone in a wheelchair listening, or a coach of someone in a wheelchair, or a loved one. Kind of help you understand the difference between diagnosis and function, and give you some hope as to what's next after an injury that can put you in a wheelchair. So with that being said, I hope that this episode provides any of you listening hope, whether you're in a wheelchair or not, that there's always a what's next. No matter what your doctor says or health professional says, you can always find your tribe and you can always improve your function. So with this one too, it's not going to be a video based, it's all audio based. All right, so the things you're going to learn with this episode is you're going to learn the various conditions that put people in chairs and some more information, kind of the nitty gritty of the diagnosis itself. Again, not the function necessarily, but the diagnosis. Secondly, you're going to learn about the function and how the diagnosis does not necessarily determine one's function. It'll tell you what you can and can't. It'll tell you muscles that'll be working, what kind of sensation you'll have generally. However, function is how you perform primal movements and your ability to adapt and work with this new body, this new kind of movement you have. So function really is determined by your ability to adapt. The third thing you're going to learn is a little bit about how we categorize, especially in the functional fitness realm, which is a great way to embody and help yourself mentally and physically, obviously, but cope with this new skin you're in, this new way of moving, this new mindset. Getting out and moving again and training and sweating. And it doesn't have to look like rehab, especially if you're post that rehab stage. Like, you don't need to be fearful. There's a lot of things you don't need to be fearful of anymore. So the third thing you're going to learn is a little bit about how we categorize those who are in wheelchairs. There's 3 different levels that we do, and we think about that not only as an athlete, if you're listening, but as a coach and then a loved one, of just levels of assistance that is needed. Think about it like that. Levels of assistance needed to do the primal movements. It can be done by everyone. It just might look a little different based on the level of injury. And to include in this objective, you're also going to learn a little bit about assistive equipment. So before we get into the nuts and bolts here of this, I have had the opportunity to work with many, many wheelchair athletes, and they've all taught me so much. So most of what I'm going to be sharing with you today is stuff I've learned just from kind of being in the trenches with these men and women. And I am not a spinal cord injury expert as a physical therapist. What I am is a movement specialist and a functional fitness expert. So I'm very capable of taking someone who doesn't move what you consider normal and bringing them into a fitness environment and helping them achieve the same task that anyone else is achieving in the gym. Let's say there's a squat. Well, someone in a wheelchair can still squat, and you'll learn here in the episode how they will do that. So most of the things I've learned, I took classes in school on spinal cord injury, and I've studied on my own. I've done self-study, but a lot of this is just through asking questions to my athletes, learning more about them, and what they can and can't do and what they struggle with. So it's also, there's got to be a level for you, whether you're a loved one, the athlete, coach, having an open dialogue with your health professional, with your coach, with your loved one, with yourself, even being completely honest of your challenges that you have, as well as your successes that you have. So with that being said, let's get this party started. I want to put some faces with the names though. So these athletes who taught me a ton include, and you're going to hear them in these episodes coming up, Keith Konkar, who is a lower thoracic spinal cord injury that he got it in Hurricane Katrina. You'll hear from Jaime Baltazar, who also has a spinal cord injury, a lower spinal cord injury, who is a wheelchair basketball coach and basketball player who was in a gang shooting. He was not part of a gang, but was at the wrong place at the wrong time as a young child. You'll hear from Allie Armstrong, a young lady who's an occupational therapist who was in a sledding accident and now has a spinal cord injury. You'll hear from Mark Brown, who is a Border Patrol agent who experienced a major traumatic brain injury from a rollover accident, and that's what put him in a wheelchair. You'll hear from Elena Nichols, total daredevil, 6-time Paralympian athlete, skiing, kayaking. I think there's some other ones in there, but she's just a ninja. You're going to hear from her about her experiences. She's a lower thoracic spinal cord injury athlete. And then you'll hear from Darius Jones, who is a naval veteran who is in a motorcycle accident. And he is a new father, and I think his son is now 2 years old, which is pretty cool. So, and he is a higher thoracic spinal cord injury. I also have another athlete who will go unnamed, who had an infection in his spine, a fungal infection, which is very rare. And he has a mid-cervical spinal cord injury from that. And it's incomplete, which you're going to learn about here in a little bit. But he is able to stand with support and extremely strong-willed, very healthy man, and very inspiring. All of these individuals are very inspiring and motivating. So they haven't let these injuries, and the stories you're going to hear, they haven't let these injuries determine how they're going to live their life anymore. Yes, the injuries were hard to get through, really hard, and some took years of kind of coming out of a period of just not knowing what's next and not feeling there was a what's next, to absolutely crushing and finding their tribe, getting strong, and living a happier, healthier life now than they were previously. So I think that that's what is the most awesome thing about all this, is that most of these individuals' lives are extremely enriched now. Not that they weren't before, but they've used this experience to make their life even better and not let it limit them. So their possibilities are still endless. And a lot of them in their stories talk about this wheeled life and how there's so many perks with the wheeled life, which I'm excited for them to share with you. So first objective, what are the conditions that put people in wheelchairs? And most of what I'm going to be talking about here are the reasons, the people that I've worked with. And there are many reasons that put people in a wheelchair, but I'm going to talk about the most common. The most common one, actually, so there's 4 that I'll talk about briefly, but the most common one is spinal cord injury, which I'm going to go into a bit of depth, because that one is one that people don't really understand. So spinal cord injuries are pretty severe injuries to the spinal cord. So think of the spinal cord like right now, you're sitting maybe in your car or sitting at home or standing. The spinal cord is like a hose that goes down your back, and it's protected by vertebral bodies. And the end of it is the brainstem, and which turns into the brain. And then you've got the, call it the horse's tail, cauda equina, the lumbar, lower back region that turns into a bunch of nerve roots that go into the sacral region, like our kind of bikini line area. So, but again, any trauma to the spine is severe. Even if someone comes in with a strain or sprain in their back, I still consider it a very severe case. Not that I'm going to sit there and send them to the emergency room, but being able to protect the spine when you move and do any kind of sport is really important. But most of the people that come in to see me who've had spinal cord injuries, it was traumatic based. They couldn't control that. And so their injuries to the spine are pretty severe and involve either a complete severing of the spinal cord or partial severing. So understand that because the spinal cord and the brain are the most important aspects of our ability to move, feel, experience the world, experience our environment, that plethora of things can happen when, with different areas, different levels of your spinal cord are injured. So as one of my athletes mentioned, spinal cord injuries, it's like snowflakes. There's not one snowflake alike. It's kind of like that with spinal cord injuries. Not one is alike. They all are a little bit different, partly because of the human and the human's character, but also just because of the spine controls everything. So the things that are affected in each person is a little bit different, and even the function might be a little bit different. So, okay. So the things that can be affected, basically cardiovascular, gastrointestinal, integumentary, respiratory, to name a few. And what I want to read to you right now is a kind of a good, and I'll put this in the show notes. It's from the National Institute of Neurologic Disorders and Stroke. So it gives a good idea of how does the spinal cord work. I really like this description. So to understand what can happen as a result of spinal cord injury, it is important to understand the anatomy of the spinal cord and its normal functions. The spinal cord is a tight bundle of neural cells called neurons and glia. And the nerve pathways, which are called axons, that extend from the base of the brain to the lower back. It is the primary information highway that receives sensory information from the skin, joints, internal organs, and the muscles of the trunk, arms, and legs, which is then relayed upward to the brain. It also carries messages downward from the brain to other body systems. Millions of nerve cells situated in the spinal cord itself also coordinate complex patterns of movement, such as rhythmic breathing and walking. Together, the spinal cord and brain make up the central nervous system, the CNS, which controls most functions of the body. The spinal cord is made up of neurons, glia, and blood vessels. The spinal cord itself. The neurons and their dendrites, which are branching projections that receive input from axons of other neurons, reside in an H-shaped or butterfly-shaped region called gray matter. The gray matter of the cord contains what we call lower motor neurons. This is getting real nerdy, people, which branch out from the cord to muscles, internal organs, and tissues in other parts of the body, and transmit information commands to start and stop muscle movement that is under voluntary control. Upper motor neurons are located in the brain and send their long processes, axons, to the spinal cord neurons. Other types of nerve cells found in dense clumps of cells that sit just outside the spinal cord, called sensory ganglia, relay information such as temperature, touch, pain, vibration, and joint position back to the brain. The axons carry signals up and down the spinal cord and the rest of the body. Thousands of axons are bundled into pairs of spinal nerves that link the spinal cord to the muscles and the rest of the body. The function of these nerves reflect their location along the spinal cord. So, here are the sections of the spinal cord you want to think about. The cervical spine. which is basically cervical level 1 to 8, emerge from the spinal cord in the neck and control signals to the back of the head, the neck, the shoulders, the arms and hands, and the diaphragm. So it basically controls your breathing, which is super important. Control of the hands, control and the feeling in the back of the head. So the thoracic nerve, spinal nerves, which is thoracic level 1, base of the neck, to the top of the low back, T12, T1 to T12, emerge from the spinal cord in the upper mid-back and control signals to the chest muscles, some muscles of the back, and many organ systems, including parts of the abdomen. The lumbar spine nerves, L1 to L5, emerge from, so lumbar 1 to lumbar 5, the low back, emerge from the spinal cord in the low back and control signals to the lower parts of the abdomen, the back, the buttocks, and some parts of the external genital organs and parts of the legs. Lastly, the sacral spinal nerves, S1 to S5, emerge from the spinal cord in the lower back and control signals to the thighs and lower parts of the legs, the feet, most of the external genital organs, and the areas around the anus. The outcome of any injury to the spinal cord depends upon the level at which the injury occurs in the neck or mid-back or low back or sacrum, and how many and which axons and cells are damaged. The more axons and cells that survive in the injured region, the greater the amount of functional recovery. Now, in my eyes, function, again, it's how you perform primal movements. So think about when they talk about function in these research articles and academic articles, think about it as what muscles can work and what sensation is like. But that doesn't necessarily equate to how someone will perform these primal movements, because it depends on, just like anybody, their movement intelligence, their movement background, if they're an athlete or not before. So loss of neurologic function occurs below the level of injury. So the higher the spinal injury, so the higher, let's say in the neck, the greater the loss of function, the ability to use the rest of the body. So that doesn't mean they can't perform primal movements, they just need more assistance. Their function, their ability to use their muscles and their sensation might be significantly different and will be significantly different depending on the height of the injury. But their function, again, a high-level thoracic injury and a low-level thoracic injury can still perform a squat. Depends on one's athleticism and their ability to adapt quickly. And that includes proper compensatory patterns. So we'll go into that in a little bit. So a whitish mixture of proteins and fat-like substances called myelin cover the axons and allow electrical signals to flow quickly and freely. Myelin is much like an insulation around electrical wires. It is formed by axon insulating cells called oligodendrocytes. I haven't heard that word in a long time. So axon insulating cells are called oligodendrocytes. Because of its whitish color, the outer section of the spinal cord, which is formed by bundles of myelinated axons, is called white matter. The spinal cord, like the brain, is enclosed in 3 membrane layers called meninges: the dura mater, the tough, which is the tough, most protective outermost layer, the arachnoid, the middle layer, and the pia mater, which is the innermost and most delicate layer. The soft, gel-like spinal cord is protected by 33 rings of bones called vertebrae, which form the spinal column. Each vertebrae has a circular hole, so when the rung-like bones are stacked on top of each other, there's a hollow canal with the spinal cord with the spinal cord that lives inside of that canal and is like a channel going up to the brain. The vertebrae are named and numbered from top to bottom according to their location along the backbone. 7 cervical vertebrae in the neck, 12 thoracic vertebrae attached to the ribs, 5 lumbar vertebrae in the low back, and then below them, 5 sacral vertebrae that connect to the pelvis. And then, of course, there's the coccyx below the sacrum, which is our tailbone. The adult spinal cord is shorter than the spinal column and generally ends at L1, L2, vertebral body level. A thick set of nerves from the lumbar and sacral cord form the cauda equina, which is considered, another word is the horse's tail, in the spinal canal below the cord. The spinal column is not all bone. Between the vertebrae are discs of semi-rigid cartilage and narrow spaces called foramen that act as passages through which spinal nerves travel to and from the rest of the body. These are places where the spinal cord is particularly vulnerable and this is the area where the spinal cord is particularly vulnerable to direct injury. Okay, woo, that was a great little message from the National Institute of Neurologic Disorders and Stroke. I really liked that synopsis of the spinal cord itself. It gets a little bit nerdy, but I would recommend checking out the link I provided and do a little bit more research on your own. But it just goes into the depth of the capacity of the spinal cord and what it can do. So if anything, just remember the level of the injury will determine what muscles and what kind of sensation one's going to have. But again, the function is going to be different in most cases. That's one's ability to perform primal movements. Okay, this is like a little lecture, but in the podcast format. So a little bit of information about spinal cord injuries now, just overall prevalence. 12,500 spinal cord injuries occur a year. The majority of them happen because of motor vehicle accidents, but some can happen because of gunshot violence, domestic violence, infections, falls. Typically, the most common is in males, and the average age is around 43 years old. Now, just the different types of injuries. So you know now about the cervical spine, the thoracic spine, the lumbar, now the sacrum, but now let's look at complete versus incomplete. So if someone has an incomplete injury to their spinal cord, that means that the cord, whether it's in the cervical spine, the thoracic spine, the lumbar, is partially severed. And so there is some activity in the muscles and nerves below the level of injury, maybe, and above the level of injury, of course. They'll have the majority of their function. So their function can still be very high, typically. And this is 60% of most cases, spinal cord injury cases, end up being incomplete. And there's various types of incomplete injuries that you can look up, and then I can provide resources for. There's a general resource, spinalcordinjury.com has a list of them. There's central cord syndrome, anterior cord syndrome, Brown's cord syndrome, and there's more. Complete injuries are basically fully severed spines. So this eliminates any activity below the level of injury. So let's say it's a mid-thoracic, like a T6 or T7 level injury. Anything below that, technically, any muscles or sensation isn't going to be there. So sometimes there's a little bit, depending, but typically no. So they still retain function, I should say, activity above the level and no below, but they can, again, still have high function. However, a very common message when someone is injured with a complete spinal cord injury is you're not going to be able to do a lot of things. And that's simply most of the individuals I've worked with in a wheelchair have proven their health professionals, even family members, and themselves wrong. So, okay, now there's a really talked about function. Okay, let's talk about the ASIA scale. So the ASIA scale, I'm going to go back to this reference for the National Institute of Neurologic Disorders and Stroke. So if you look at the ASIA scale, it's basically the American Spinal Injury Association impairment scale. I guess it's called AIS now. When I was in school, it was the ASIA scale. So it's okay. So it's called the ASIA scale, and there's A, B, C, D, E classifications, and will have this link in the show notes. But A basically is a complete spinal cord injury, no motor or sensory function below the level of injury, and this includes the sacral segments S4 or S5. So bowel and bladder is affected completely. B is an incomplete spinal cord injury. So classification B, there is sensory but no motor function. Function is preserved below the neurological level and some sensation in the sacral segments S4 to S5. So they might not be able to control bowel and bladder, but they can feel down there. C is incomplete. Motor function is preserved below the neurologic level. However, more than half of the key muscles below the neurologic level have a muscle grade less than 3, so not strong enough to move against gravity. So in physical therapy, we test muscles on a scale of 0 to 5. So 3 plus, you can move against gravity, 3 you cannot. D, incomplete. So this means motor function is preserved below the neurologic level, and at least half of the key muscles below the neurologic level have a muscle grade of 3 or more. Joints can be moved, so the joints can be moved against gravity. E is normal. Motor and sensory functions are normal. So oftentimes when someone has a spinal cord injury, they're going to be classified A, B, C, D, or E. And they're going to have the complete or incomplete with it. And that's going to involve various sensation in some areas, loss of sensation in some areas, motor in some areas, loss of motor in some areas. It really, again, everyone's a little bit different. And it really depends on the level, incomplete or complete, and then the actual location, if it's incomplete, of where it is on the spinal cord. Is it the front, the back, the side, the center? So while this is a lot of information about the spinal cord itself and the spinal cord injury classifications, now we're going to get into a little bit of the function, which is more of the fun stuff. But first, let me just go over the other 3 things that can put someone in a wheelchair that I've seen. And this isn't all of them. So being a bilateral above the knee amputee can put you in a wheelchair. So a lot of amputations a majority of them happen because of diabetes mellitus. But the ones that I've worked with have been pretty active individuals before and were either Marines, the Navy, Army, and were involved in IED blasts. So they lost their legs above the knee, and it's just easier to ambulate in a wheelchair. And you can imagine they have a pretty high level of function because they're able to get out of their chair pretty easily, full access to their spine, etc. Another one that I've seen is a major traumatic brain injury who, in the rollover accident, had a crushed pelvis. So his major traumatic brain injury left him very weak on one side, and there's a lot of dyskinesis with his movement. So being in a wheelchair while he can stand, he needs a lot of support, and it's just easier to ambulate in a chair. And then the last one, which is very rare, is fungal infections, which happened to one of my athletes. High cervical or mid cervical spine, incomplete, can still stand and with support move around, but very much uses his chair a lot and has a lot of one-sided weakness. So it's pretty impressive what these individuals have done in terms of function. You would think a cervical spine level of spinal cord injury can do next to nothing, and that is untrue. So now let's go into function, which is my favorite part. So when it comes to athletes, there are, especially athletes in wheelchairs, I like to just kind of put them in 3 different categories because, again, the categories will determine the level of assistance they'll need in terms of tools, not necessarily people, but tools or assisted devices. So level 1 is so typically who we've seen in the gym, we've seen some cervical spinal cord injury athletes and major traumatic brain injury athletes in wheelchairs. But level 1 is typically your incomplete spinal cord injury or thoracic T6 to T12 could be incomplete or complete. So if it's higher than T6, it's typically an incomplete spinal cord injury, meaning they have some function below. Typically a cervical spine patient or athlete who has a complete injury will need a lot of assistive device and won't necessarily be making their way into a functional fitness environment without a health professional with them. So these individuals I've worked with have come on their own, are incomplete above the level of T6 or complete or incomplete below the level of T6. Okay, so in the level 1 case, they have access to their arms for the most part, and they also have a lot of abdomen in their back. So it might be different on one side versus the other. So the right side of their abdomen works better than the left, but they still have access to their abdomen and their back muscles and their arms. Typically they're paraplegic. Sometimes they're quadriplegic. Quadriplegic can still be incomplete, incomplete. So, but again, it just really depends. Can they use their arms, and do they have some access to their abdomen and back? So people can come in with these diagnoses, but don't be scared of them. If they are a thoracic level, lumbar level, even lower cervical level, I should say a thoracic level or cervical level in this level 1, and can use their arms and part of their abdomen, move around and sit up on their own, then they belong in this level 1. If they cannot sit up on their own, then they're going to want to have someone there with them, like a health professional or a loved one. Okay, so with level 1, they may need with things like, so primal movements. What are we talking about with primal movements? Squatting, right, lowering your center of mass, lowering and raising your center of mass, hinging, bending over and picking something up, right, very functional. Pushing something, pushing a baby carriage, pushing a cart, pulling something, pulling someone towards you, and then carrying an object. So typically with those primal movements, a level 1 will need some kind of assistance, like in the form of a band, right? If they're going to hinge over, they're going to need some support from a band. If they're going to carry something, they're going to need in one arm, they're going to need to use their other arm to support themselves on a chair. Things like that. Level 2 is the lumbosacral region. So the lumbosacral region is, can be complete or incomplete. But these individuals, they have a lower spinal cord injury, and they have more access to the muscles and sensation above the level of injury, which means more abdominal muscles used, more back muscles used in a thoracic level, maybe even some hip flexor used if they're incomplete. A lot of them are on bowel and bladder programs. Regardless of the level, a lot of them have bowel and bladder programs, and they typically know what to do, and they know when they need to take bathroom breaks. But and that should not weird you out as a coach or a loved one. That's just the way it is. But these individuals need less assistance when they do things like squatting, raising and lowering their center of mass, hinging, pushing, pulling, and carrying. However, sometimes you'll find, and I'll give you some resources at the end, like if one side's a lot weaker than the other, which is what you'll find a lot with a TBI, someone with a traumatic brain injury or spinal cord injury, like they're going to need maybe assistance on one side where they won't on the other. And then you've got level 3, which is typically your bilateral above the knee amputee who is no spinal cord injury, but they just lost their legs above the knee, and being in a wheelchair is easier. So they have full access to their spine. So they can hinge, they can raise and lower their center of mass, push, pull, carry pretty easily. So the things to think about, the other variables. So you've got those levels of function there, things to think about. They just need, so the level ones just need a little bit more assistance. The level threes don't need as much assistance. Squatting, for all of them is going to look like a dip, using their arms or their legs. So they're raising and lowering their center of mass without a lot of access to their hips, right? Unless they're level 2 or level 3. And, but they're still getting that same motion that anyone else is getting. It's just they're using different muscles to get it. So I say my protocol, and I'm going to end up doing research on this one day, is that someone in a wheelchair should be able to do 20 dips, no problem. You use your arms as legs. You have to transfer your body from surfaces like couches to chairs, chairs to bed. And so there's a lot of dipping and pressing going on. And if you aren't able to move your body weight freely and quickly and with ease, you're going to end up with shoulder problems, and you're going to end up becoming more sedentary. So it behooves you to get freakishly strong in your upper body, as well as mobile and stable. So again, hey Dexter, my cat's here to join me. The level, so doing a squat, everyone can do it. A level 1 just might need a little bit more assistance with the band underneath their butt than a level 2 or level 3. Hinge, a level 1 might need a little bit more assistance on their trunk than a level 2 or a level 3. Carrying, they might need assistance with their hand, so on and so forth. So I have a course that I co-created with Max Conserva called Functional Training for the Adaptive Athlete. And it is a way you can learn different ways to adapt these primal movements for different levels of spinal cord injury or someone in a wheelchair. Again, your diagnosis doesn't necessarily determine your function. So let's wrap this up with some basic information about wheelchairs and just equipment. And then we'll let you guys go for the day. So you've got, with devices and equipment, the wheelchair, that you get from the hospital day one is usually an adjustable wheelchair. You don't want that to be super snug. You want it to have a nice cushion so we don't get pressure sores, right? Pressure sores can be a problem for a wheelchair athlete, and they'll tell you that. So they're constantly adjusting their position throughout the day, or should be. I think the rule of thumb is every 15 to 20 minutes, giving yourself some pressure relief from being seated. But it shouldn't be super snug on the thighs, on the side, behind the knees, and the seat back should be supported for your level of injury. So if you have a high level injury, you might need a higher seat back. If you have a lower level of injury, you might need a lower seat back. The goal is to eventually lower the seat back as much as you can over time so you can start to improve trunk strength, right? The lower the seat back means the more you have to control your trunk. So a sport wheelchair looks a little bit different. It looks like wings almost. It's got a higher seat back. It's very snug. It's like a body part. Fits like a glove. It's not something they're going to want to sit in forever, maybe an hour or two, because there's going to be rubbing going on. But they're pretty awesome. They move really fast. But there are no brakes. Wait for it. No brakes. There's different chairs for rowing that you can have too, that are snug as well and that limit the leg piece of it, so they can just work on the arms and it straps the athlete in, which is nice. If you're a lower, like a level 2 or 3, just being able to sit on the rower, we usually use a band to strap the rower down. It really forces midline control and can challenge them in that way. So it depends on the workout and what you want to get out of them. But remember, like a level 2 is really going to probably struggle with sitting there. It's going to be good for them. But if you're going to be doing a really long aerobic capacity workout, you might want to consider using a rowing chair. So stability straps is another one. Sometimes people just tie their shoelaces together, or they use wrist wraps. But the point of stability straps is to not let their legs be out of control. So with a spinal cord injury, sometimes they don't have access to their legs a lot of times, and the legs can spasm, like their trunk can spasm when they switch positions. So you don't want, when they're doing things like a Turkish get-up, a partial Turkish get-up, or rowing or squatting, their legs flopping around out of control, because it's only going to throw them off. So you use stability straps for that. And a lot of the athletes just, again, use wrist wraps, their shoelaces. We use bands. You just want to be mindful of skin irritation. Okay, so with that, you learned a lot about function. You learned about equipment. And I hope that's given you hope, whether you're an athlete in a wheelchair, a loved one of an athlete in a wheelchair, or coach, hope that there is a what's next. And there's a lot of things you can do to improve your function that your medical provider probably didn't give you. So remember, Functional Training for the Adaptive Athlete course is a great resource. There will be resources in the show notes based on the articles I have quoted. And if you all have any questions, please email me, teresa.larson@movement-rx.com. Key takeaways, right? Function isn't, your diagnosis does not have to determine your function. Your function is related to primal movements. Building strength in your arms is crucial. Having mobile arms, stable arms, and being able to do 20 dips, no problem, man or woman, is key. Finding a wheelchair, finding a nice wheelchair that works for you. Also, a sport that you love to do before your injury, that you haven't found a tribe or a team to be on since. There are resources out there to do that. There are wheelchair teams for everything. And then you want to make sure you perform self-care on the front of your shoulders, such as your pecs, because you're always pushing, and doing some strength work for your posterior chain, so it's the back of your shoulders and your spine, the muscles that surround your spine. And with that, I will leave you with a high five, a good night, a good morning, wherever you are. I'm coming to you from sunny San Diego, and I look forward. Next episode is with Keith Conkar and Chase Jontiam, and a story and an experience that will be mind-blowing for you. So have a good night. Thank you all for listening in to this episode of the My New Normal podcast. I hope it resonated with you and where you're at in your life. Know that you can change. I think there's a lot of power in knowing that you can change. And through these stories that you're listening to, you're seeing it, you're listening to it, real life changes that people have made after some significant injuries and diagnoses they have received. So with that being said, remember, it takes action first to change the mind and change the body. You have to take that action, and you will then find the motivation, and you can thrive in this new normal space. With that, have a good one and pay it forward, my friends.